right, well, welcome everybody. This is Karen Van Calo. I'm the President and CEO of the Florida Healthcare Coalition, and this is the second meeting of our collaborative around better pain management for employers. And as you've all heard me say many, many times before, we could not offer these kind of educational opportunities without the support of our affiliate partners, and PSERA is sponsoring this year-long effort around better pain management. So a special thanks to them for the support that they provide to us. We are going to leave the lines open for you all, but ask you to please self-mute your line if you're not presenting or not asking a question, and that will help minimize any background noise for the presenters. And if you prefer to ask questions, which we'll ask for after each section of the agenda, if you prefer not to ask them, you can chat your questions to Ashley Tate Dinger, who's listed as the host on the webinar, and then I'll ask those questions on your behalf. So we are going to send the slides out to you. We'll have a recording. If we don't get to all of the questions that are asked today, we'll send you the responses from our experts when we follow up with them. There are probably also going to be materials referenced in the presentations, and we'll get those out to you as well. We have a really packed agenda. If we could go to the next slide, please. As you can see, in the hour and a half, and we are going to start off with Kimberly and Cindy giving a report out from the Benefit Design and Communication Work Group. I'll turn it over to them in just a moment. Kimberly Eisenbeis is Administrator of Insurance Communication and Health Promotion at Orange County Public Schools, and Cindy Crump is the Wellness Coordinator at Lynx. And then at 11:45, we're going to turn it over to Lois Adams, who's the President and CEO of the HHCS Health Group, and she's going to be talking about some sort of alternative and multifaceted approaches to dealing with opioid abuse. And then for the last hour of the webinar, the Midwest Business Group on Health has developed an employer guide to pain management, a toolkit that Larry Boris, my counterpart at the Midwest Business Group on Health, and Heather Sell from Pfizer will co-present, and Heather is medical outcomes specialist there at Pfizer. And then real quick at the end, Carlene's going to talk about the next steps for us with the collaborative, and we will call it a day on pain management. So I am going to go ahead and say next slide and let Kimberly and Cindy jump in and get us going. Thank you.
Thanks, Karen. This is Kimberly. Can you hear me okay?
Yep, you sound great.
I'm unmuted. All right, great. So, yes, I'm Kimberly Eisenbeis with Orange County Public Schools, and Cindy Crump from Lynx and I have been working with Carlene and Lori from the Florida Healthcare Coalition regarding the Better Pain Management Communication Work Group. And we're working through 4 tasks, and I'll go ahead and report out on the first 2 and let Cindy take the second 2. So our first task was to provide feedback on the document that you can kind of see on the right of that slide there, which from what I understand will be on the microsite and everyone will have access to it. And the title of the document is To Take Care of Your Post-Op Pain Control. So there are 7 questions on the right side of that document, and we were looking for 5 questions to something for patients to use as a discussion with their providers on a plan for their pain. So we did get rid of 2 of them because we thought that they were covered within the other 5 questions. The ones that we're choosing to use are: how much discomfort is usually associated with this procedure? How can I minimize the need for opioids? What non-opioid options do I have? What do you need to know about me to help customize my pain management? What happens when the medications from my surgery wear off, and how will my pain be managed at home? And finally, what can help my recovery? So all of those, you can kind of see beneath the question, there is an explanation. So it's more than just giving them the questions. We're letting them know why you want to ask these questions. And then the second task was to determine the different communication vehicles to use during annual enrollment and health fair events for employers. So there's, a range of somewhere between 7 and 27 times that you need to hear something before you remember it. So we were looking at the different options as far as wallet cards, pocket calendars, rack cards, and magnets to use at these events. And so we did decide that as many options as possible so that people will see it. The rack cards will have the 5 questions with the information, and the magnets can be specified for the employer group to be using them, as well as the pocket calendars, and to use PDFs and electronic formats for our websites and newsletters. And while we were thinking of the wallet cards, because I know the Consumer Reports has a wallet card with the 5 questions similar to that, these questions require more of an explanation, so we did eliminate that option. Cindy?
All right, awesome. Thank you, Kimberly. Can you guys hear me okay? Okay, well, this is Cindy Crump here from Links. So the other 2 things we looked at for the communication pieces is to come up with a slogan. So something that employees can see and they know what it's about. And the two most popular that came up is pain is personal. And that's something we saw on the website that's on the Plan Against Pain website, and it says, because everyone experiences pain in their own way, nobody can predict exactly how much pain you'll feel after surgery or for how long. So I know, Carlene was mentioning she doesn't need a strong medication. She's fine with Tylenol. I'm the same way. So that pain is personal would kind of make people think, okay, maybe I don't need this medication just because everyone else is taking it. The other one is Plan Against Pain, just to keep it all uniform with that form that you see there at the top. That would be the main title. So whether it was on a magnet, on the rack card, the very first thing you would see is the Pain is Personal or Plan Against Pain. And then it would have the subtitle, which we came up with 5 questions you should ask before surgery, and those are the ones that Kimberly just went over. And then it would have the explanation underneath it, except for some things. I think we said the explanation might not fit. And then the last thing we were talking about is if dental procedures should have their own communication piece, and we decided that yes, they should, simply because some people may not associate dental work with surgery, but it's important to know, since they do prescribe opioids with some things. So it will have their own cards, and the main title will stay the same. So it'll be Pain is Personal or Plan Against Pain, and then the subtitle will be 5 questions you should ask your dentist. So then that way people know that there is a difference, but the questions would stay the same. It's just if they're going to the dentist as opposed to at a hospital for another procedure. So those were all the things with the communication pieces. The next step would be for the committee to meet again and look at the graphic designs, make sure it looks good and ready to go for when open enrollment comes, and employees will be able to understand it pretty easily. And the goal is to have all the communication pieces done and distributed to the employers by August 31st, of this year, obviously, August 31st.
Wow, thank you for all your hard work in such a short amount of time. We really appreciate it. Does anyone have any questions for Kimberly and Cindy? Carlene, is there anything to weigh in on this work group if folks haven't joined it yet, when the next meeting is? Anything you can add in here?
No, what we will do is send out, once we get all the pieces together, we'll get the work group back together again to approve and give their input on the graphics and the different pieces. Folks are more than welcome to join. So if they're interested, just send me an email.
Sounds good. I know, Cindy, when you were talking, you mentioned open enrollment, but these materials could be used, at health fairs that are, different from what might be held in conjunction with open enrollment, but would they also be available if there's, an on-site health center? What are other ideas maybe for the use of these materials?
Yeah, absolutely. Like Kimberly mentioned, once they get to that time, their open enrollment will already be over, but I believe they have a health fair or something along those lines going on. So these are definitely great for open enrollment. Health fairs, for me personally here at Lynx, the bus operators, there's almost 800 of them. They love the rack cards. I'll post them up there when they're entering from the bus, and they'll pick one up. These could be, held in the, wherever your benefits department may be, and if, someone hears that someone's about to go get an operation, it's kind of just used as a little handout and a reference that employees can go to and kind of decide what might be the best path for them.
Okay, sounds good. All right. Any? Go ahead.
Karen, this is Rosa. Kimberly and Cindy, this is amazing, and thank you for bringing this to us. I have a question. Is there an opportunity of partnering with the healthcare plans to having that engagement communication occur when the patient is advised of needing the surgery?
I would think so. I don't know how that process works with each of you. It might be different between each employer and the carriers.
Okay. Yeah, that question, I would have to get with Brian over here from Benefits to get more details on how that would work. And Rosa, I'd be happy to get with you once I hear what, what kinds of things we can do with that.
Sure, because unless you have, and I think the health fair and everything we discussed, every opportunity of having that, conversation with the member, that personal interaction is what makes a huge difference. But I may not have a surgery now, and I may, when I unfortunately need a surgery, may have forgotten, what information was provided. So it may be an opportunity, when the member is informed that they need surgery, of educating them on these wonderful tools. And we can discuss it, and maybe that's something we can work with Cigna to posting online, maybe.
Yeah, absolutely.
And this is Kimberly. Typically, an insurance carrier will reach out when they know you're having a procedure done or something to tell you, to perhaps steer you at a different location or, minimally invasive procedure versus an open procedure. So that would be great if they could talk about the pain aspect at the same time.
Yeah.
So that would be a step at the prior authorization phase then.
Yeah.
That sounds good. That's a great suggestion, Rosa.
Yeah, and the other thing, has there been conversation of potentially using this on the workers' comp arena?
I don't know if the work group has talked about that, but certainly when we had the first meeting of this group and some subsequent conversations, it's become readily apparent to us at the Florida Healthcare Coalition that not only on the medical pharmacy benefit side, it's really important in the organization to have, that workers' comp piece dealing with these same, issues. So I hope so is the answer.
Okay.
I would encourage, I guess each organization is, works differently, I think, between those two sectors. My take, Rosa, is that some organizations have a very, very thick, strong firewall between the two, and others are more integrated.
Yeah, ours is very integrated, so it's something I would definitely see what opportunities are there, because we are an integrated, program here at the school board. So, okay, awesome.
Terrific. All right. Rosa, I don't know if you have anyone from your area over there at Miami-Dade Schools who wants to, jump in on this work group if you don't have someone already, but would certainly appreciate your insight. I know you're such a busy lady, but maybe there's somebody there. So, all right. Thanks. Any other questions on this piece? All right. Thank you again, Kimberly and Cindy and the rest of the folks working on this. So I am going to turn it over to Lois Adams from HCS, sorry about that, health group. Lois, I think you're on. I can see you on the chat box there.
I'm here. I wouldn't let you down, Annie. I'm here.
I know that. All right, great. Lois, I'll turn it over to you. Thank you very much.
Well, what I wanted to talk to was a multifaceted approach to dealing with the opioid crisis. My past history has been as an assistant director of pharmacy at Orlando Regional Health Center, and my job there to cover the 4 hospitals was the inventory and narcotic controls. And even the Florida Medical Association sent people to me when they felt that physicians were getting too cozy with some of these opioids. But I would give them classes in how to write narcotic prescriptions. But the crisis has really gone out of hand, and there actually is a multifaceted approach to dealing with this opioid crisis, and it's not just, telling the doctor what they can prescribe and can't prescribe. Could I have the next slide, please? Opioids are natural or synthetic chemicals that bind to receptors in your brain or body to produce morphine-like effects to relieve pain. Now, opioids are really derived from the opium poppy, and of course there's a lot of that grows over in Afghanistan, and this is where a lot of the heroin comes from, and then from the heroin, which is a class 1 narcotic, comes down the morphine and the oxycodone and Dilaudid. Fentanyl is a synthetic opioid, and it has become a real problem. When I was at the hospital, we talked about the fentanyl fun packs, where people who were working up in the surgical unit used to be able to get hold of fentanyl. They would take it, and of course, my approach to that was, if I had to go up there and as a director of narcotic controls, which was only one of my jobs, but to go up there and find them or see them and catch them, I used to say you get to a plea bargain 3 days off the end of your sentence. So that was something that we did. So they're natural and synthetic chemicals. Next slide, please. Well, where do we begin so that we can assist employees who are addicted to opioids? My first thing is that we should, have drug testing. We need to take some psychological exams. There need to be other things. We need to be much more careful in our hiring practices so that we don't get this integrated into the society and the culture of our facilities. Next slide, please. So how does addiction start? Well, it starts from prescriptions from healthcare providers, just as we heard, and many times there are surgeons who perform the surgery, and lo and behold, the first thing they do is they write for controlled substances, and then the patient starts taking them, and then lo and behold, they can't get off of them. And so we have even had patients who came down in busloads from Kentucky. They'd go to Boca Raton, they would get prescriptions, 5 prescriptions for narcotics, come up to the Orlando area and try to get those filled. Well, that just didn't happen. Our job, I think, as a healthcare professional is, one, to try to get them off of those, or I would send them to a pain specialist. I honestly believe that when you have these results of surgical services were prescribed for pain and intake continues uncontrolled, that if you have somebody like that, that person needs to be referred to a pain specialist, either a board-certified specialist or someone who, and they're usually, those people are usually anesthesiologists, but they do the best job. I worked with one personally. One of them was in my facility for about 18 years, and he only prescribed about 3 in an entire day. I mean, he had other ways of taking care of it, and there were things like intrathecal morphine, biofeedback, TENS units, things like that, to try to take care of that. And then, of course, those things which are obtained through unmonitored medicine. There are new dark webs, which are internet webs that most people do not have access to, but drug dealers do, and people buy these drugs from things like the dark web. They can get them online, and they're mailed to them in little packages to their home. Now, that's a hard thing to deal with, and, you know, you talk about heroin addicts. The other thing that is really, really concerning is that these patients who have known to become addicted and have gone through rehab, they have things on the internet, they have things on their Facebook and so on and so forth, and these dealers track them down and make them compliant, just like we do with patients on important drugs. They try to do a compliance and adherence program on them as well. And so it becomes very difficult because once a person is prone to be an addict, they can very well become one easily. So then the drugs may start with the use of things like marijuana. Cannabis or THC should only be dispensed by a licensed pharmacist. And I think that's what we're going to be talking to the legislature about, is that if you're going to dispense a drug which can be a gateway drug, something like that, that ought to be dispensed by a licensed pharmacist. And those are the things I'm going to be talking with our own Mike Miller here, a representative, about how these things should be dispensed, not in a pot shop. Because if this is for medical marijuana, then medical people ought to dispense it. In addition, THC can be very harmful to children. There's a reward and motivation center in their brain. I've had people, of course, a lot of this came from California, but they had big conferences where children have walked off balconies. They got into their mother or father's drugs, and even the pets got into drugs. And now the veterinarians are having a fit out in Colorado because they have become addicted. Next slide, please. Now, we need to start by understanding the types of addictive behaviors. Addiction can be and is genetic in some cases. So the behavior is due to born addicts. They have the genetic predisposition to become addicted. In type 2, is the stress. It lowers the brain endorphins, and endorphins are important in the brain to have a feeling of well-being, and it increases craving behavior. So the opioids actually enhances the reward side of the brain by releasing dopamine into this, and it helps block the effects of stress. Type 3 is the drug and alcohol toxicity due to prior ongoing chronic drug and alcohol overuse. At a political function that I attended, one of the things that we were talking about was the fact that these things were not, alcohol was the biggest gateway thing to overuse, and that's why people needed the marijuana. This is part of the argument. And did you know that chronic alcohol lowers brain endorphins? So those people who have alcohol toxicity, the brain endorphins are lowered, and that's one of the things they keep taking it and taking it to see what can be done. Next slide, please. And that's where a clinic who specializes in a treatment process for addiction could become a very valuable tool in the employer taking a look at how these things ought to be addressed. The first thing you have to review is the employee's diet, their activities, and environmental factors. What are the things that are causing them either stress or putting the part or adding to the part of the genetics to find out what the problem really is? Why are they not well? And then there's diagnostics to be able to be done determine patient profile and a specific disease status. And when you talk about personalized medicine and personalized plan and that sort of thing, I think that's what we're really talking about here. Everybody is different. You can't just blanketly just try to take care of it. And then you answer such questions as, are they a slow, moderate, or rapid metabolizer of drugs? One of the things that I presented to the Board of Pharmacy and to the Board of Medicine and was told that they are now looking at the genetics of patients to see how they do metabolize them. In other words, well, how should these doctors dose these drugs? If they're a slow metabolizer, these drugs are going to remain in the system for a good while. A moderate or rapid metabolizer. If they are a rapid metabolizer, they metabolize it much more quickly, and then the dose needs to be increased. So you need to really give the dose that is most appropriate for that person. Do they have a reward deficiency syndrome? And what's their risk assessment for addiction? And after you do all this, then you can treat the causes of the employee's addictive cravings. And no two patients are the same. It is a personalized training or treatment. Next slide, please. The clinic's treatment process can include, one is a lifestyle advice and coaching. There's nothing like having somebody who knows what they're talking about continue to talk to this patient and advise them and coach them when they get weak, have a line that they can call if they get weak. There's the creation of the balances of the gut, the immunity, and the physiology. So this is all health care. We then examine the key role of inflammation in their addiction and reduce it, instruct them on proper nutritional supplements for inflammation and pain to decrease the prescription drug abuse. That is so important. And there are for addiction and that sort of thing, there are a number of nutrients and supplements in the body which need to be replaced and replenished because it drives them out. And then they are no longer well. There's a neurofeedback program that can be done. Biological treatments, big pharma, and natural supplements, bioelectrical treatments, and repeat diagnostic program and adjust to the treatment. And that has to be tailored to each individual. Each person is such an important human being, and if they have been caught in this web, we need to see what we can do to take care of it. Next slide, please. Coaching. This can include a dopamine-boosting program for a lifetime in recovery. Yoga, dopamine-boosting foods, meditation, and cleansing the brain. Inflammation is part of something that we need to cleanse, and that's the cause of many, many diseases. Spiritual practices, trauma therapy like brain spotting, exercise, with 12-step programs and traditions, and a reward deficiency solution system. That reward deficiency center is in the brain, and what we need to do is make sure that we address that as well. Next slide, please. Our goal is to improve the employee's overall quality of life, work, productivity, and decrease illness. And we can screen out those patients and employees who should not even be there, because after all, you are running a business. And you need to have somebody who's with the program and can take care of their everyday things and be of value and help the employer do a really good job. But then those who become addicted for some reason, whether it be surgery or whatever it might be, we have a duty, I believe, to try to improve their overall quality of life, work productivity, and decrease their illness. They will be a far better employee, and they may be even a better employee than they would have been before. Next slide, please. And so if you have any more information on this, please contact me. There's my contact number and my email address, and I will be happy to help you with some of these programs. I think it is very, very well done. I have seen patients who have come in with for the Suboxone treatments and things like that. That's not really getting at the root cause of what is causing this addiction. And of course, we need to take care of those things which only the authorities can take care of, such as the heroin dealers and those people who are they stalk these people and try to get them back on the drug. That has got to come to an end. So I am very passionate about this program. I've done work with narcotics for a long time, and I would be more than happy to help anyone who needs the help. Thank you.
Thank you so much, Lois. We appreciate your passion so much in this space and your knowledge. And again, just to reiterate, if any of the employers on the phone need information and referrals, I know Lois would be happy to point you in the right direction in terms of these really comprehensive and holistic programs. Does anyone have any questions for Lois? We probably would have time for maybe one. No, don't hear anything. All right, well, if you have questions for Lois, go ahead and email her or call her, or if you want to send them to us, we can pass them along. And Lois, thank you so much for finishing right on time. We're doing really well here, so thank you.
Well, I had some help, so that was good. Karen did a great job.
Okay. All right, well, we're going to go ahead and switch gears to Larry Boris and Heather Sell to take us through their employer guide that they put together around pain management at the work site. We were making as part of our agenda for this year's collaborative to put a toolkit together, and then we found out about the guide that Midwest Business Group on Health had put together in collaboration with Pfizer, and we certainly don't want to reinvent the wheel, so we thought it would be a great idea for them to take us through what's in the guide, and we can certainly utilize this employer guide with our employers. If there's additional things that might need to be added or tailored for Florida, we could certainly add that to our microsite as well. So I'm going to go ahead and turn it over to Larry and Heather. I know Heather's on for sure. Did Larry come and join you, Heather?
I'm right here, Karen.
All right. Hi, Larry. Good morning.
Good morning.
All right.
So thanks very much. We very much appreciate the ability to share with you this work that we've done, and it's a part of a building effort of other coalitions. Karen's also heard me say we used to call it plagiarism, now it's best practices. We learn from each other's groups and what they've done and adapt it to our own. And so what we're going to present today is efforts that we have put together based on some of the work that's been done both by other coalitions as well as an internal group of employers and researchers that have worked with Midwest Business Group on Health here. So let's go to the next slide briefly. Again, this is Heather and myself. I serve as president of Midwest Business Group on Health, and Heather is our key contact at Pfizer for medical outcomes and has worked with us a number of years. We're very pleased to have her here. Next slide. So MBGH, similar to the Florida Healthcare Coalition, is a nonprofit group. We focus on increasing the value of health benefits for our employers, improving the health and productivity of the workforce, and addressing quality, cost, and safety in the marketplace. We are made up primarily, on the next slide, you can tell, of large self-funded companies. This is just a sampling of our 120 members. Most of whom have headquarters or operations around the Chicago metro area, but all are national self-funded multi-state firms. Next slide. So these are what I call our buckets of activities. We advocate for the purchaser perspective on healthcare. We do a number of benchmarking surveys on strategies, policies, tools, and issues employers are concerned about. We conduct virtually monthly educational programs that are simulcast as well around the country. We have networking opportunities for employers who have the same issues or health plan or health system to come together and share thoughts and ideas. We have opportunities for research and advisory boards that we conduct, and of course our staff supports our members. And regarding the research, what we find is that a lot of times some of the work being done by consultants or brokers or vendors are not done with a purchaser perspective on it or needs of employers or a good understanding of the workforce itself. So we partner with groups like Pfizer and others to try to create things that are employer-focused and really aim at improving, the health and productivity of the population, reducing the cost of the bottom line for the employer, and helping people be more effective healthcare consumers. So let's go to the next slide. So our focus on pain management came about as we looked at the research that was out there. We looked at the cost and the impact on productivity that we see, the prevalence of the issues of pain. And when we think of pain management, we're also thinking then headaches, we're talking about back pain, we're talking about accident pain, workers' comp pain. Whenever somebody in the workforce has a situation and is prescribed medication or is trying to address something because they can't function well at work, they're either consumed by the pain itself or just the thought of bending a certain way or just the stress of the situation. And so we look at the research and we see that it's costly from a variety of perspectives. And unfortunately, though, employers have really struggled to make a business case for this because the management of it and the costs are spread along on a whole number of other kinds of conditions that people might have. And so it's not categorized necessarily as pain. But it is, when you look at the data, and that's some of the things we'll talk about, the key is looking at the data, you get a perspective on really the total impact it has on your population. Heather, please jump in whenever you'd like to here. Next slide. So what we did is, once we did a survey of our members to identify what their knowledge was and how they're addressing pain in their population. We created an advisory roundtable of employers who were interested in this topic to look at the problem of pain management and its associated problems of overuse of opioids and gaps in knowledge, and ultimately then came up with this document, this tool that will be on our website and will be available to any employer, any coalition who wants to take advantage of this. And so the Employer's Guide to Pain Management, the worksite, is something that we will make available, and we're hoping that it'll be a living document as well, that's something that can be improved or we can modify or as things change. Next slide. So let's quickly go through the results of our survey just in a couple of slides. So when we asked them, what were your most frequent conditions, not surprisingly, musculoskeletal, headache and arthritis and joint problems. We asked about the most common medications that are used categorical-wise. Is that a word? Karen, you'll have to help me with that. Antidepressants, opioids, and NSAIDs were the key. And the key approaches to ensure it's only appropriate use of medicines are used, prior authorization, step therapy, quantity limits. But what was, again, unfortunate is many employers just do not know what their health plans or PBMs are doing. They don't know what the data is out there, and so they can't effectively make use of their vendor partners and resources. Next slide.
Can I jump in a second?
Please, go ahead.
Okay, I'm sorry. So one of the things I wanted to clarify, this is Heather Sell from Pfizer, was that when we did this survey, we gave them a huge long list of conditions to choose from. And so the most frequent that we see, a lot of people focus on just back pain, but back pain was also included in the musculoskeletal. And so people think, okay, maybe I have an issue with back pain. But what was important is we did do a survey, and we also, for a couple of the employers, looked at their data in aggregate. So we compared their data with the other common conditions like cardiovascular disease, diabetes, and we saw that prevalence of back pain alone was similar to the cardiovascular conditions. But when you look at everything all together, like Larry had said, headache, arthritis, a lot of the other conditions, fibromyalgia, that prevalence was much, much higher than any of the cardiovascular conditions or diabetes or things like that people tend to spend some time on. I think if you're not a clinician, you look at the most common medications to treat pain, I think antidepressants may puzzle you. But if you think about pain and the way you treat it, one of the things that's very, very important is to figure out the type of pain and what's appropriate for the different types of pain. And so I do have a counterpart that, like myself, I work with the MBGH. You have Sue Heinemann, who also works with the Florida Coalition, and she could probably spend some more time. We have some other resources from Pfizer to help explain the different types of pain. And it's also in the document. So we have a nice little chart that outlines the type of pain and what's the appropriate medication class to treat that. And so if you think about the different buckets, there's nociceptive pain, which is, you have damage to a tissue. If you have nerve pain or hypersensitivity, that's when the antidepressants or these agents called anticonvulsants come in, and those actually are first-line therapy for those types of pain. Opioids in general are last line, and they're actually inappropriate for certain types of pain like fibromyalgia. They make it worse. They're totally inappropriate for migraine. There's really no evidence that they work for back pain. And what we see is 50% of the time, they're used first line for some of these conditions. And so that's where we feel that there's some education that needs to be to happen. And when we first started out, we have a lot of tools from a Pfizer perspective for providers. We wanted to say, let's create a tool for employers to see what we can actually do. When we talk about step therapy, we talked about this last week, step therapy, if you think about adding that to an opioid, has limited impact, because I know when I used to work in the retail pharmacy, people would come to me with an opioid prescription if it was either going to be denied by their health plan because it was either filled too soon or there was some other reason that the health plan wouldn't cover that. They're more than willing to pay cash. So barriers to opioids, for the most part, they're generic. They're relatively inexpensive, and you just think about what your step therapy, what the impact's going to do to your opioids. So if you're putting step therapy in place for maybe some of these antidepressants, anticonvulsants, is that making it easier to get opioids? So that was why we asked the question, and so we kind of went through the results of the survey to make these recommendations that you'll see on the upcoming pages.
Great. Next slide, please. So additionally, we found, again, a vast majority of employers did not require patients to see a specialist prior to being prescribed more than 2 weeks of opioids. The employers just were not tracking that. We found most employers did allow someone on opioids to return to work, though with some restrictions, and Heather will comment on that. 3/4 of the employers had trained supervisors, but again, that means a quarter of our members or our purchasers out there have not trained supervisors, who are really the first ones who could identify the problem with work, with productivity, and the potential of opioid impairment. We found most employers did not know the number of employees on paid leave who were taking an opioid, and over 80% did not know the number of emergency room visits of their populations caused by opioid abuse. So, it's clear that having data is key, and sometimes you just don't know where to start or what to look. So, next slide. So what we recommend in this guide is focusing really on looking at your plans, your PBM, all those others, to identify where are the costs of pain, where are the costs of addiction, what is the business model to improve the treatment, and in the guide then to really look at what are the implications of different treatments, both drug and non-drug, and what are some of the safeguards that you need to have. And so what you'll see is that within each guide, there will be a set of recommendations on each section. Heather?
Yeah, so the feedback that we had four or five employers go through and look at all of our recommendations, and the feedback that we had from them in terms of how they would use the guide is they would take, granted it's 20 pages, so you're not going to take all 20 pages to each vendor, but we have it broken down by health plan, vendors for recovery, vendors for addiction treatment, pharmacy vendors, what you would take to each of those vendors, and sit down and have a conversation with them and compare their offerings, if they have a program in place, to what do they have included in that program with what's in the checklist.
Great. So next slide. So where to start, again, it's all about mapping your data, and that's kind of a term of art, I think, that we've learned in working on a number of data projects, is employers need to understand that it's not just the health plan and pharmacy data that they have, but there may be a whole number of vendors. There may be a lot of internal sources, your productivity, your absenteeism, your workers' comp, your disability side. Who has your data internally and externally? And then you need to bring all that together to identify the trends, identify the potential problems, and learn where you'll really get the most kind of insight. And then once you have it together, bringing those vendors together with your consultants or whomever you like to work with, and create a real proactive approach going back to those vendors working together, and be sure to include the specialty data, which is really key. Next slide.
Yeah, just to comment on the specialty data, because a lot of times you don't think of traditional pain through specialty, but if you look at some of the pain conditions, one of the ones that pops up commonly is rheumatoid arthritis and osteoarthritis. And those two have very, very different treatment options. So if you have osteoarthritis, the drug of choice is basically acetaminophen or Tylenol. If you have rheumatoid arthritis, the drug of choice is a disease-modifying agent or agents that you have to get through a specialty vendor. A lot of times these are very, very, very expensive. And so you want to look at the adherence of your patients who have these high-cost drugs to make sure that if they're walking away from these high-cost prescriptions or they're not adherent to them, which the purpose of those medications are to stop the inflammation and actually get people into remission. If they're supplementing with opioids because opioids dulls the pain, it's not effective for the pain treatment, number one, and number two, you still have disease and this disease that's attacking the body, and it's not being controlled. And so those are things you might want to look at through the specialty pharmacy that, are these patients taking their medication?
So the slide now, again, what we've got in the guide is a set of sections that then have a series of different types of recommendations. And each recommendation covers a lot relating to how you should both engage with the healthcare vendors and internal and external staff, and then what's the priority you place on these. So essential recommendations would be those that we believe are the first kind of thing you should do. They're relatively easy. They have a very high value. The second are strongly recommended, things that we think can really increase the value and benefits. And then there's a variety of optional recommendations that include other kinds of approaches that you can consider, things that you either can do easily or you may want to address. Next slide.
In terms of the optional, now there were some, we struggled with this a little bit because we felt they were all important, but in terms of optional, not everyone has access to all of their data, and so some of the optional recommendations are optional just because we know employers may not have access to some of the data for those recommendations.
Great. So here you have the table of contents for the guide, and we're going to go fairly quickly through each of those sections. We don't have all of the information that's in the guide that we're going to display, but I do have just the key elements of that. There's a variety of sidebars and charts that are not included in this presentation that you'll be able to find. And also, just so you know, we have not yet loaded this up on our website. We have a certain format and template we'll be using. So what you're seeing is really the first public release of this and one that we will continue to make available. So next slide. So starting out, working with the health plans, overall in general, we think that it's key that, the plans and the PBMs and your vendors, they need to know you want to address this problem. They need to know this is a priority for them. And it doesn't matter whether you're a small or large employer. It does matter that you have focused this, and this is your vendor, this is your partner, this is the one that's contracted to improve the health of your population. And so you want to make sure that they know you want them to look at the data and focus on the appropriateness of care and prescriptions. You want them to identify what are the quality metrics that are used to identify those conditions and those treatments and look at the providers that are doing it. You want to review the current benefit design that you have and that are being offered under those benefits to see where do you need to change. And then just a very broad caveat or important one. The data, we used to say garbage in, garbage out. I don't see that much anymore, but data clearly has its limitations. Heather, would you go through these, please?
Sure. Yeah, so I think one of the struggles that we had, and obviously diagnosis codes are important, and we've had some switching in terms of using ICD-9 to ICD-10 codes, and I'll talk about that a little later on. But making sure that something is coded appropriately. If it's not coded, you can't capture it. And then in the commercial databases, you're not going to miss over-the-counter medications. So if someone is using an over-the-counter such as Tylenol, Motrin, things like that, those aren't going to be included in your claims like they would, let's say, if you were in the hospital or through a Medicaid system. And as I mentioned before, patients may choose to pay cash for prescriptions, including opioids. Now, if they pay cash, they're not going to be adjudicated through your PBM. However, they will be encoded if you have a state monitoring program. However, the employers don't have access to the state monitoring programs like the providers do. So providers are encouraged and mandated in some states to make sure they check the state monitoring program before they prescribe something, but the employers don't have access to that level based on HIPAA, so they're not going to know that, but the providers will have it. Next slide. Next slide.
So again, another broad guideline that we're suggesting is that when the diagnosis and treatment information is brought together, when you're able to aggregate your pharmacy and plan data, look at the conditions where opioids may be used, such as fibromyalgia, thank you. When you get a lot of pain in the body, migraines, abdominal pain, back pain, you have to be, creative. Well, not creative. Actually, what you'll find is that later in the guide, we literally have a set of ICD-9 codes that should be used to identify these conditions. And so you also then want to work with your vendors to assess the quality metrics to see how they can improve what they're doing and get increased coordination between various subscribers, providers, with the patient, et cetera. And if you have a worksite clinic as well, how to connect all those dots. You want to be able to look at all your data and see who's undertreated. Maybe there are people who have these conditions that are painful who need certain kinds of additional support, whether it be medication or non-medical support, to manage their pain to make them more productive, improve the quality of their lives. And then consider additional interventions where you have prescriptions for now naloxone that can be used to address these kinds of chronic opioid conditions. Care coordination is really key here. And finally, working with your PBM to incorporate appropriate contract language that addresses those kinds of innovations. Heather, comment?
Yeah, so I was going to focus on the naloxone piece. I know most states, and I think I looked up that Florida is included, where you can get naloxone without a prescription. And so I think the health plans are struggling with, do they cover that as well? When do you cover that? And if you see a prescription for naloxone, do you put any other, like Larry mentioned, the care coordination steps in place? So naloxone is basically an anecdote or a reversal if someone is having an overdose. And so one of the things that we try to do with this document is we have some recommendations that are published by the CDC and for the Institute of Medicine. And so we're trying to say these are clinical recommendations, but how do you implement these from a benefit design standpoint? So things like if I'm on a high-dose opioid, if I'm on an opioid in combination with something else that's going to cause respiratory depression, like a benzodiazepine, then the Institute of Medicine and the CDC recommend that you add naloxone potentially if there's a risk for an opioid overdose. Some of the health plans may reach out and say, okay, well, if you have a naloxone prescription, is this a red flag that you need to have this prescribed by an abuse provider or someone who's certified in working with people who have addictions, or is this something that you need to do outreach? So some of the health plans will put a prior authorization or something like that in place. Others will just do care coordination behind the scenes as a follow-up reactively.
Great. Next slide, please. So let's begin. So when working with health plans, the essential recommendations that we're suggesting are, number one, again, request the data and analysis. Make sure you've got it all. You're particularly focusing on inpatient, outpatient drug and emergency room for multiple admissions, opioid abuse, and other dependents. As I indicated in the back of the guide, as you'll see briefly, there are codes both for ICD-9 and a link to ICD-10. You want to ask the plan and PBM, are they doing their own outreach? Are they going to targeted providers, patients, even dentists, to see if, in fact, those people are overprescribing or even if they're aware of a patient's situation? And finally, consult the plan and legal counsel about various coverage options and requirements. Next slide. When we go to just strongly recommended, again, review the data to develop an overall picture of the impact of pain on the population, identify utilization patterns for patients who have particularly painful conditions on sites of care, and identify the most costly and common conditions in those populations. Again, the glossary in the back, not the glossary, but the appendix, which lists out the codes, will help identify those kinds of conditions and may help you easily focus in on then for your population or whatever the employer's group is, what's most important and where they should address that. Next slide. For benefit design considerations, our essential recommendations are, number one, evaluate the coverage options. Make sure treatment approaches are affordable, convenient, and easily accessible. We want to really allow for referral to comprehensive pain centers where appropriate. You know, many of the drugs initially prescribed are by primary care physicians who may not be aware of what the needs of that patient truly are. They may not have a good understanding of that particular condition the person has or the pain that they're doing or the impact of these medications. So getting some collaboration with other providers and specialists is really key. Next slide. Other benefit design considerations that we strongly recommend, really focus on the non-medication therapy options. There's a plethora of different approaches that have now been supported by clinical evidence, and even some states may mandate it. You'd have to look in Florida whether or not it addresses that. But a number of the interventions that we have looked at, both in conjunction with medications or in lieu of or prior to, can make a difference. So things like acupuncture, behavioral health, chiropractic, medical massage, physical therapy, and yoga have all been shown to have some real benefit. And just as a sidebar, one of the other groups that I work with is the National Association of Worksite Health Centers. They have looked at those employer clinics that use chiropractors, and those chiropractors are integrated into their medical teams and addressing for non-medical issues, problems with back and neck injuries. And they've found a tremendous savings, both in cost and reduction in the use of opioids, improved outcomes. So these are not necessarily independent chiropractors who are out there by themselves, but those that have been integrated into the medical staff. But you need, in chiropractors, there's a variety of different types as well. So you want to make sure that whoever you're using and recommending is certified in what they're supposed to do, and that you've had some good experience or you've got some referrals for each of these. But clearly, they offer options, and there's materials that you can get to look at other options and backgrounds on employer experiences with each of these. Next slide. When we look at addiction recovery in your benefit design, we think there's certain things that are essential. Number one, counseling. Counseling is really key. You know, people have these problems and they just don't solve them the first time around. We think counseling should be continued for a minimum of 90 days in duration. You can't have 3 or 4 visits and think that that's going to necessarily do it. The EAP should be consulted on how they best approach it. Their kind of data should be shared with the other vendors. There may be some privacy issues, but clearly I think between the providers they can do that. And you want to make sure your medication coverage for opioid treatment includes these other kinds of things that are available to prevent them, to prevent abuse when appropriate. Heather?
Yeah, I think the one thing that we heard, we did consult a PBM with some of these recommendations, and some feedback that we've had, and I don't know if this is consistent throughout, that they would cover, let's say, buprenorphine or naltrexone, but not methadone, or vice versa. And so the recommendation from a clinical standpoint is to cover them all. And so just to make sure that it's available, and whether they receive that through the health plan or through the PBM, just to make sure that those are available at whoever the appropriate vendor.
Thank you. Next slide. So when we look at the, so counseling, as I mentioned, is really key. And so what we find is there's a whole list of different types of counseling that you can include, and you should include, under your health plan and PBM to cover recovery addiction. And you can see all of these listed here. I won't go through them all. But you want to find out, do you have access to these? Does your EAP and plan, do they have resources to recommend for people to use? And if so, how much are people being recommended or referred to these kinds of places? Next slide. Now, when we move to PBM, or your pharmacy benefits, again, our essential recommendations are always number one, gather the data. What kind of prescriptions are being done? And then clearly, as an employer, you're not going to be looking at individuals, just the aggregate, but you want to find out what is the status of this problem, or is it a problem at all? You want to know. Your PBM may have in-house programs. A number of the organizations have these. Take advantage of them. Understand what their components are. Do they include the monitoring? Is there an added cost on these? You know, as long as you're paying for the services, take full advantage of their resources. You want to review the patient profiles to see, are they getting it from multiple sources? Are they using different types of medications? Are they combining these? Are there certain prescribers who are frequent in writing the same kind of prescription or more than one medication for the same patient? And then there's a variety of other data out there. Heather?
Yeah, and these are just things that the PBM can offer, and so this is what the list of recommendations, again, that they can provide if you want more detail, so this is what they have access to.
Thank you. Next slide. So you want to see where can you intervene and assist patients where the abuse might be either suspected or might be a potential out there. And so we really think that at the point of sale, at the pharmacy or through the PBM really is a key element of this. And so you want to talk to your PBM or the retail pharmacies that you use about these kinds of approaches to make sure that they are checking on this, that they're doing their reviews, that they're talking to the patient, that they set certain limits where it's appropriate. Heather?
I think one of the caveats when you get into this detail is what do you do when people do hit a higher dose? What do you do at the point of sale? Do you reject them or do you follow up later? There's some controversy. If you just reject them, they're going to go somewhere else if they're in pain and they want their opioid. So how do you have them go through the system appropriately so that they can get either pain control or get recognized to be into a program that can support their addiction if it's identified at that point?
Okay, next slide. Other essential recommendations, make sure that your PBM plan, TPA, conducts a retrospective drug utilization review. You want to know who are the prescribers, who are the pharmacies where there's being overutilization or duplication. It wouldn't surprise you to learn that there's very few in your total network, but they probably represent the large majority of the abusers or the overprescribers. You want to find out about the members that you have in your population who are exceeding the thresholds that they need. You want to make sure that in your PBM plan there is outreach to the pharmacies to find out what's going on, to talk to them about that, to review those medications that are appropriate. Heather?
I was going to say, I'm going to explain a little bit what this MED is, or the morphine equivalent dose. And so that's kind of a controversial and very clinical thing to have oversight over. So a morphine equivalent dose just means all the opioids that you can take, they have a morphine equivalent, and you figure out what that is during a total daily dose. And it's very, I would say, patient-specific. So if you've never taken an opioid before, 10 milligrams would probably knock you out and make you cause you an overdose. If you've been taking a lot of opioids for a longer period of time, 10 milligrams may not touch your pain. So you have to kind of keep that in perspective. There are some thresholds when you get too high where we know the risk of overdose is greater. And there's a table or a little info box in the guide that I'll refer you to that explains this nicely. But so this is why we talked about earlier, it's so important to have a specialist on board to make sure that these patients are monitored, because a high dose may actually be appropriate for an end-stage cancer patient, but it may be very, very harmful for someone with their first dose. And so this is why monitoring is so important. The one thing that's also needs to be careful that maybe not be a respiratory depression overdose is that there's a combination a lot of times with acetaminophen. And so acetaminophen is just Tylenol. But if you combine that and you get a high dose of Tylenol on board, because people are pushing the doses of the opioid, you can have severe liver damage, and that's something that your PBM can be watching out for as well.
Thank you. Next slide. Other benefit design considerations for your PBM. Again, you want to review and have in there when it's appropriate for opioids. You want to consider having it almost like a step therapy where prescription is only after failure of other non-medication approaches. You want to do the quantity limits to make sure that it works, it's the right dose, and it's not being used for anything other than acute pain. You want to find those that are immediate release formulations before you do something that has somebody on a long-acting term. And clearly, adherence is such a key part of all medications, and particularly these. You want to find out the patients early on who have poor adherence. Now, when I say we, as the employer, you're not going to do that, but you should be able to have something where the providers, there is a tool, I think, an adherence tool. You can almost check to whether a patient is going to be adherent or not on any kind of medication. And perhaps your PBM can help educate providers or prescribers on these. Next slide.
Yeah, I think the poor adherence is important for the non-opioids. People who are on opioids are pretty adherent to those, but if they're not adherent to non-opioid therapies and they're using opioids to supplement, that's the problem that you want to try to address.
Heather, would you go through this slide, please?
Sure. So for the, a lot of pharmacies are offering a lock-in. So if you know someone's on a condition where they've tried everything else and they are going to be on opioids for a long term, you're having them lock in with just one pharmacy, one prescriber, and that's the recommendation that the PBMs are recommending, the health plans as well. The other thing you want to look at is I think I mentioned this before, look at your benefit design. Are your co-pays for the non-opioid therapies making barriers to those medications that may be first line and encouraging opioid utilization where it's inappropriate? And then also think about your coverage for naloxone and when that's appropriate to have the reversal agent. What the CDC recommends is those with a history of overdose, those with substance use disorder, you need to have a medical claim or a prior authorization to know that. Higher overdoses higher doses, or if they have an agent that can also cause respiratory depression, just make sure that they have access to naloxone. Again, your state's saying that you can get that without a prescription, but think about your coverage for that. Do you want to cover that as well with or without a prescription?
Next slide. Optional recommendations would be require an assessment for patients in certain situations, those who have just gotten on the opioid, people who have been on it for a number of times, for at least 3 months, those who are on a high dose, as well as those who may have some potential tampering with lower doses. We want to offer, as Heather mentioned, the abuse deterrent and tamper-resistant opioid formulations, and ensure pharmacists cannot override a rejected claim without an exemption from a physician.
Yeah,
please.
Okay, so for this, what we found is that a lot of times if we put restrictions on a quantity limit, if people are increasing the dose or of a high dose and all of a sudden they stop without tapering, that's where the monitoring comes in with a specialist or even any primary care provider. We're finding the tapering discussions not happening. And so that's why we encourage this monitoring, continuing monitoring, so they can easily get off it and don't have those withdrawal symptoms without the tapering. The abuse deterrent opioid therapy, this really is, again, last line, but you want to make sure what these drugs do will prevent people from crushing them, snorting them inappropriately, injecting them, and so it's making it difficult to abuse them. Doesn't do anything to stop them from taking a whole handful, but again, it's preventing that manipulation, and so covering that is very important. The last thing, we talked about having a reject for those opioid medications. It's important, but also think about they could pay cash and still get the opioid if the pharmacist is able to dispense it.
Okay, next slide. So now we want to turn to long and short-term disability. Again, as we mentioned at the very start, you want to find all of your data that impacts this, and clearly pain is a problem in disability. So you want to compare your industry with doing some benchmark with other peers. And the the Integrated Benefit Institute does have some overall comparisons that you can look at, and you should be able to track these over time. So if we go to the next slide, you can see the chart then. So this is, Heather, why don't you walk through this?
Yeah, so this is just an example. If you go to the IBI website, and all employers, I think, should have access to that through the Florida Coalition membership, or you can go online and you can search by your industry. And then this is an example of all industry types. And so what you do here is you just start by looking at the conditions. If you have access to the data for what conditions you're paying for short-term disability, if you're above benchmark, maybe you do a deeper dive in terms of how they're being treated. You know, are they being used with an opioid that's inappropriate? But start here and compare your data with the benchmark.
Next slide. So you'll see there's also information from the IBI on long-term as well. So again, something to look at, give you again some ability to see where you're standing. Next slide. Workers' comp is another key area and one that often is siloed from the group health data. So you want to make sure you pull together all the data from this as well on the pharmacy and the health side. You want to do some clearly assessments on high-cost claims. And again, look at national benchmarks over time regarding those employees who get prescriptions, who have opiate prescriptions, those who have different formularies. You want to try to make this consistent as possible with what your medical plan is doing. Next slide. So internally, you want to look at with your legal counsel as well to make sure that you're complying with state and federal regulations as relate to workers' comp. You want to ensure that your policies are up to date as far as what documents you have to have. Some employees will have to sign certain policies indicating they've read them, and you want to prohibit inappropriate use. Finally, again, the importance of managers in this, and I can't emphasize this enough. You know, people are most influenced on their job by their supervisors and managers, and to make sure these managers are aware of their role, their responsibility to oversee what's going on, and encouraging employees to notify managers when they're on a condition so that the manager can identify early on if there's an issue or have a conversation about resources. Next slide. For drug testing, Heather, would you go through this, please?
Oh, sure. I think that the take-home here is just to make sure that you are consulting with your legal team with what's appropriate, and then, you know, testing with all of these recommendations for instances. But just if you're doing the random testing, to be randomly consistent is very important. So. Next slide.
So privacy and confidentiality are fundamental, or people will not be willing to share or participate in this. You want to have a process of intervening when it comes to drug testing, discipline, of course, if necessary, and make sure that you include all kinds of prescriptions, not just certain illicit ones. So drug testing is really key, but you want to have the kind of policies that protect you and the employee. Next slide. Heather?
Yeah, so I think the one point, the last point on the slide is the typical panel for testing does not include synthetic opioids, and that includes oxycodone, it doesn't include methadone, and that wouldn't include fentanyl either, which we're hearing a bunch on the news lately. And so if you have a panel, you work with your lab for what testing you're going to use, just make sure you include the synthetic as well. So we just wanted to highlight that as well. Okay, next slide. Yeah, and so these are just standard things to consider in terms of, you know, employment policies, and I think this is kind of self-explanatory. There's a little bit more detail in the guide. But.
Okay, next slide. So education is going to be key for managers, especially, in helping to detect. And we also then recommend that, you know, we have programs for employees, those who are on medications and those who have family members who are on it as well, so they understand how to self-manage themselves. They can understand what are some alternatives for not taking medications. Generally, people would prefer not to take meds if they don't have to, particularly this issue. And then there's clearly some good sources. The CDC has a great education and information on this problem, as does the American Board of Internal Medicine and Consumer Reports. So next slide. There's a program called Choosing Wisely. And this is free for employers and employees, and essentially gives people information on when and when not do they need medication, what they can do elsewise. Choosing Wisely does offer even a free website and materials for employers that you can get through Consumer Reports. Next slide. So we have a brief glossary that's in the guide as well, talking about some key issues or terminology that'll help you identify and get a good understanding on some of the things that we've talked about and some terms that are used in some of the recommendations. Next slide. So lastly, we have a list of the codes. This is just the first half of the first page. There's several pages indicating what should be the ICD-9 codes, and again, as we've mentioned, there is a link to ICD-10 that'll help then in your gathering of your data to find out what's there. Heather?
Yep. So the one thing I would highlight in terms of the code, there's 3 appendices. The first is the different conditions, which it's in the published literature. One of the things that was controversial or struggle for us was to try to put everything into certain buckets, and so based on what was in the literature, we were able to define this, because you can see there's multiple for ICD-9, and it's exponential now for ICD-10. So the first appendix is all the codes for pain. The second is what you want to do for comparison. So if you want to run all your data, or you could just run whatever in Appendix B, which are the most common cardiovascular codes, if you want to try to put things in perspective. Appendix C is also very important. It lists all the codes that are published in the literature in certain categories for abuse, misuse, and poisoning. There are separate codes for heroin that are not included in that chart, but it's specific for opioids, and so that would be something that you can run. I've worked with several employers, or they have other coalitions actually that have databases, and they use the ICD-9 codes that are in that table to look retrospectively. It's very difficult to find a benchmark by industry type on your abuse codes. And so if you want to look over time, let's say you take 5–10 years, you can see if that number is increasing or decreasing, and look to see if the interventions that you put in place, some of the things that Larry and I went over, if that number is changing, if those codes are going down in terms of the abuse, misuse, and poisoning. So that's something to think about. And then if you want to look at anything from 2015 and 16 on, you need to use the 10 codes and use the crosswalk that Larry had mentioned.
Next slide. So we want to thank you for giving us some time, and we hope you benefited from the work that we've done. Heather and I and Susan would be pleased to share with you the full document, of course, and answer any questions. So Karen, I'll turn it back to you.
Okay, great. Wow. Thank you so much, Larry and Heather. That was a lot of information, and we will be sending the PowerPoint to our employers, certainly the employer guide as well. We do have a couple of questions so far, and then, if folks want to unmute their phones, they can ask you directly. But do you have an ETA yet, Larry, on when the guide will be posted on your website?
Well, we'll probably post it in this kind of format or as a PDF, I would say, in the course of the next week or two.
Okay.
But we've got a new approach on our toolkits on our website that allows people to click on just the section that they want, and they can have quick access. Unfortunately, as Heather said, you've got 20 pages you got to go through to find something here, so it's not as user-friendly. But this should be up and around, I'd say, in the course of the next week or so.
Okay, so what we'll do is keep in touch with you all so that we can then push that out to our folks as well, because I know they'll be, looking forward to diving in on some of these different areas. I just wanted to add that we are a campaign partner with Choosing Wisely, and we've actually set up our own microsite, and it's split between consumers and employers in terms of information, and so we really value that partnership with Choosing Wisely, and just want to reiterate to our members that we have that on our website. I actually have a question about, I see that you got the ICD-9 codes and the crosswalk for ICD-10. I know when we work with our employers, sometimes they really would like almost a template that they can push to the carrier, push to the PBM, saying, pull this information in this way for this period of time. How far does your toolkit go beyond just a listing of the codes with maybe a sample for them?
That was such a hot topic internally, and what I'm going to do is, I know Sue and I have been talking about this, and we're trying to work as Pfizer Medical to create basically the same list and the same categories with the ICD-10. I would say work through Sue And as soon as we have that available, I think we can, that's something that, we've paid Truven, we work with them to categorize that, put those into the same categories that are in the appendices. We don't have permission, copyright based on what we have through Truven to present that or post it publicly, but when we have that finished and complete, you'd be able to reach out to Sue and she could provide that to you. I don't know exactly when that's going to be available, but we're working on it.
Okay, great. Well, if there's any input that we can provide in that space, we've got some folks on staff who, have a good grasp of data collection and analytics. So we will stay in touch. I think Sue's on the line, Sue, with you on that. Let's open the lines and see if anybody has any questions for Larry and Heather and Sue.
Hi there, this is Lois Adams, and I just wanted to add something. I don't know, well, just make a comment about it. There are a lot of information here about the prescription benefits managers, and yet, what they give is prior authorizations. And what I have found in many, many cases is that the prior authorizations are given by people who really don't understand the disease. And that is really a bad thing, and so patients wait and wait and wait. Pain is a real problem, and it is a real clinical problem. And there are many people who go from pharmacy to pharmacy trying to find just somebody who will help them in this issue, because many people don't want to go through all the bookkeeping and all the e-force, which we have here in the state of Florida, to try to have to deal with it. And so the other thing is that many times and I saw this when I was working with Mayor Jacobs' drug coalition, is that some of the PBMs require a 90-day supply. I know there are doctors who don't want to prescribe 90-day supplies, and yet if they don't, the patient doesn't get paid for. So those are just some of the a couple of the issues that we find as practitioners out there and working with them. And like I said, I worked with a pain specialist for 18 years. If he wrote 3 prescriptions a day, that was a lot. He used other methods to treat pain patients, and I think that this is one of the things we need to really look at, is to having a real specialist in the area take care of these patients.
That's a great comment. Thank you.
I have a couple of other things that I want to talk about. These are recent developments as far as opioids are concerned. The FDA ordered Endo Laboratories to stop the production of PAMA ER, which was the extended release oxymorphone, and because they said it was causing all sorts of problems. In addition to that, both the state of Ohio and the city of Chicago has filed suit against these makers of these drugs to stop production of them because they are causing too much grief. So that's going on. So we're already getting lawsuits against it to stop some of the production at that end. Okay.
Any other questions?
Hi, this is Ashley from the Coalition. You had said you included the ICD-9 codes. Did you include the prescription drug numbers so people can ask that of their database too?
No, that was in our original document, and it was removed, unfortunately, because we had some copyright issues for that list. So there are some lists available publicly. They're not totally comprehensive, but the drug lists are not there. I would refer you to work with Sue because we do have a database. So if you're interested in looking at your data, we have a list of things that we can help work with you to identify what drugs to pull, but that's not something that we can make publicly available, unfortunately.
Okay, thank you.
Mm-hmm.
This is Patrick Peters, County Government. Question is, when we look at pain management, and these medications obviously are prescribed by a physician, that varies from physician to physician. I think, Lois, you mentioned that, a doctor, if he prescribed more than 3 a day, that was a lot. But that varies from provider to provider. And I'm wondering, would it not be prudent to have some type of a comprehensive guide to the providers In other words, have the insurance companies or the PBMs work with the providers with respect to the current standard of protocol relative to pain management and the various alternatives that are available as opposed to just prescribing a pill.
Well, the CDC has put out guidelines for the prescription of opioids and pain medication, and I think that would be a good thing to, even to reference as to what the guidelines really should be. I think when I approached the Board of Medicine and I said something about the genetic component of all this, it's something that really needs to be looked at, because some people who have the same level of pain may require more than another, and so you can't just say, no, you're cut off. You really can't do that, but you can try to have, programs to try to alleviate that and help get them, unless it's something like a spinal situation where I mean, the thing is so bad that, they need to do other things. Of course, there's also intrathecal morphine, which they can put a little pump at the bottom of the spine, and just a small amount of morphine, it goes, and so they don't become addicted to it. However, it gives the same pain relief, but you need a very qualified anesthesiologist and board-certified pain management specialist to do things like that.
Yeah, I'm aware of the new guidelines, and that's kind of where I was going, because one of the challenges that happens is that information will come out and it'll be years before it becomes commonplace in a doctor's practice. And I think that through our contracting with the PBMs and with the insurance companies, that we may be able to leverage some ability there to have standardized treatment plans communicated to the providers so that they are aware of what the CDC's guidelines are.
Great idea.
This is Ashley. Are there any more questions? Karen is having some technical difficulties. So are there any more questions? Then I am going to turn it over to Carlene for next steps, and I want to thank Larry and Heather for their presentation. And Carlene, go ahead.
Thanks very much.
Thank you.
So our next steps, our next meeting is tentatively scheduled right now for September. Once we have a date nailed down, I will send out an invitation. I will also reach out again once we have all the graphics and more information that's laid out for the open enrollment plan. I'll reach out to everyone. If you are interested in participating, please send me an email. I do appreciate Cindy and Kimberly and Lori, who is our intern, participating on the call and giving your time. And lastly, we'll be getting some of the other work groups together. So we'll also be reaching out to some of you who have signed up to participate in those work groups and get some dates and times from you, and I will schedule a call. So if Karen is on, I will turn it back over to her.
Yes, I'm back on. I don't know. All of a sudden I got thrown off when Patrick was making his last comment, so I apologize for that. So many thanks to all of our presenters today for your time, for your effort, and also again to Sierra for sponsoring this collaborative throughout the year. I assume that Carlene indicated that if you have any additional questions, that we'll address them via our follow-up from this meeting. If you have any questions, and I think, is that all we need to cover then, Carlene? Are we good?
Yep, that's it. I think we're done.
All right. All right. Thanks very much, and appreciate it. We'll talk to you all soon.